Hey everybody, it's Julie again, and it's Friday night, end of the work week finally. So I'm super excited to be done Monday to Friday. So hope you guys had a great week. We were just going to do a quick little workshop, and I'm going to try and make it quick just because tonight's Friday, and I think we all deserve a little break. And the topic this evening is your shoulder. And I know there's a ton of you out there with ongoing shoulder issues, whether it's been a couple of months, it's been a couple of weeks, or it's been a couple of years. So this episode is just to basically give you some insight to how your shoulder moves and why you can have pain, because I think a lot of us tend to put off seeking treatment, and we can just kind of pass by with shoulder pain. We just avoid doing certain things. But I want you guys to know that shoulder pain usually can be resolved quite easily, as long as a therapist can decipher exactly what's going on with you. Now, with shoulders, there's a lot of different conditions that we can see. In the clinic or virtually, we see anywhere from a frozen shoulder. We also term it as adhesive capsulitis, basically just stiffening and tightness of the shoulder joint. As well as we see osteoarthritis. We see rotator cuff injuries, whether it be a tendonitis or a partial or full thickness tear. We see impingement of the shoulder, which we'll be talking about later because that is probably what I see a majority of in the clinic. We see dislocations from individuals who have falls, who play sports. And we see simple things like a shoulder bursitis and a bicep tenosynovitis, which is also really common. So I want to give you guys some insight into how the shoulder moves so that you can just basically understand why you typically have pain. So thanks for coming out this Friday night. I'm not sure who's local to Ontario, who's on the East Coast, who's on the West Coast. So if you guys are from away, I'd love to hear from where. So if you can, give a shout out to where you're from in the comments section, just so we can see who we're reaching and where we're reaching. So I am going to go through a couple of things first and kind of teach you about the shoulder joint. Now, the shoulder joint is a ball and socket joint. Does anybody know what a ball and socket joint is? Usually a ball and socket joint, we have our shoulder, we have our hip joint, and our humerus, which is this long arm bone, at the top of it is basically formed like a ball. The upper part of our arm is the socket. And basically that upper portion of the socket is made up of your collarbone, which comes across, as well as your scapula or your shoulder blade, as we typically term it. The two bones come together and form basically the top. So your shoulder is a very, I don't want to say unstable joint, but it has the possibility for a lot of instability because it's literally just a ball kind of situated in a socket. There's a lot of factors that play a part whether or not that ball is staying directly in the socket. So we have a couple of different things that hold it in the socket. We have our ligaments, which are little white tissues that basically keep it nice and stable, going from one bone to another bone. We also have our labrum, which is kind of like a tissue that encapsulates the socket to keep it from coming out. And then we have more of the soft tissue stabilizers. And when I say soft tissue, I mean more so like the muscular components. And we have quite a few of those, including the ligaments, but they are basically the dynamic stabilizers, meaning the muscles that are supposed to contract to keep that ball in the socket. It's in an unstable joint, it's really easy for that ball to come forward, to come too much inferior, to ride too much superiorly or posterior or laterally. So it's crucial that the shoulder move properly within the socket. Now, what a lot of people don't realize is when we elevate our arm, I'm gonna kind of do a little question of who typically has pain when they lift their arm? Do you have it when you know, hit 90 degrees, when you reach overhead? A lot of us tend to get that kind of catching pain, that clicking discomfort. So if you tend to, totally gonna do it this way, that way I can actually see you guys. If you tend to get discomfort when you're doing overhead activities, usually it's related to some sort of an impingement or mechanical dysfunction of the shoulder. And what we have to decipher is why that's happening. So let's kind of, I warn people, and as I've warned you guys before, I'm horrible at drawing, but please understand. So I had my phone the other way, and I'm pretty sure that when you read this, it's like, anybody, does this say your shoulder backwards to you guys? Somebody tell me if that says your shoulder backwards. Okay, so we're going to talk about your shoulder. When you look at the shoulder from the front, you basically have your collarbone, okay? And then you have your arm bone. Now I'm going to really make this nice and easy to understand. Okay, so in between the collarbone and your shoulder, you've got to have this little bit of space, okay? That way there's this little thing called a bursa that's kind of in between the ball and the socket so that it provides a little bit of a cushion, okay? In behind our back, we have our shoulder blade. And now that's going to be behind here. So I'm going to kind of do this little, and it kind of comes out and it joins right up at the tip of that collarbone. If you think of, when you lift your shoulder, we only think of the ball moving within the socket, right? But there's actually more than one joint that's involved when you lift your arm overhead. So we have what we call your glenohumeral joint, which is basically the ball in the socket. But we also have a really important joint, your shoulder blade joint. So basically your shoulder blade on your thorax. So we call it your scapulothoracic joint. Now, when you lift your arm, they have to move together. Now remember, a joint is basically where two bones come together. So when you lift your arm overhead, okay, this ball basically rotates within the socket, okay? But if this collarbone does not elevate or lift, what's gonna happen to this bone when you hit about 90 degrees? Anybody have a guess? Is it gonna pinch? Is it gonna abut that collarbone or that joint? It is, it is. So what we have to remember too, we talked about those dynamic stabilizers. Those are the muscles that help your shoulder move within the socket. So a couple of them kind of run around the front, some of them come around here, some of them come up from this direction. So they come in all different directions and they all have different purposes. Whether it is to pull the arm bone down, whether it's to pull the arm bone back, or as you lift the arm to keep the arm bone down. So I'm going to show you, if I keep my shoulder blade stable, I'm going to show you how far I can lift my arm. So I'm going to hold kind of my collarbone down, okay, and my shoulder blade down. So I'm going to push down. Look how far I can lift. In order for me to go higher, I actually have to let go. So when you elevate and you get that upward rotation of your arm bone, your collarbone and your scapula have to also rotate upwards. So there's muscles that actually rotate that upwards, like this, so that this humerus does not abut the top. So it's really common when we have rotator cuff injuries, whether it's a tear, a tendonitis, or frozen shoulder, that you get dysfunction of these two joints. So they're supposed to kind of move at a 2-to-1 ratio, okay? So your glenohumeral joint is supposed to move twice as much as the other joint, okay? So if they're not working and the timing is off, we tend to get pain. So it could be sharp pain with lifting. It could be pain when you sleep with your arm overhead. It could be pain when you pick up your kid and you go above shoulder height. Yes, Deb, you know what that means. So your shoulder is a very complex joint, and all the muscles in the shoulder have to provide a lot of stability to allow for proper movement. So when we do a virtual assessment, we are assessing what hurts and what doesn't hurt, okay? Do you have pain with flexion? Do you have pain with abduction? Do you have pain with external rotation? Do you have pain with internal rotation? These are a couple of the common movements of the shoulder. When we look at what movements hurt, it gives us a little indication of what muscles are at fault and what could be occurring, okay? We do some resisted tests. Does, activating your long head of your biceps hurt? Does activating your supraspinatus hurt? Your infraspinatus hurt? Your subscap? These are all those stabilizing muscles that we talked about. I see a lot of people who come into the clinic or on virtual visits, and they've been suffering in shoulder pain for ages. And sometimes it gets to the point where it's aching so much that they can't sleep, they can't function at work, and they don't realize that most of these issues are very treatable. You just have to have somebody take a look to decipher exactly what's going on. Usually, it's related to poor mechanics. So as an example, I'm going to give you a patient that I saw 2 weeks ago. It was a gentleman, he's had ongoing rotator cuff issues for a couple years now, he said, and he was complaining of an achy pain in the anterior front part of the shoulder, and he couldn't sleep, like literally was on Advil, Tylenol every couple hours. He couldn't lift the arm above like 40 degrees, and it hurt going into flexion as well as abduction out to the side. He was miserable. And he said his wife even thought that he was miserable. So we took a look at his movement. He couldn't elevate any higher than probably 40, 50 degrees with pain. Out to the side, he had about 30 or 40, maybe 45 degrees abduction. Couldn't externally rotate, couldn't internally rotate. So it was very, very irritable. So I knew something was inflamed, but there was definitely some mechanical components to it. So I asked him to kind of dig into his anterior bicep where this long head of the bicep comes. And he said it was really extremely, extremely tender. I don't know if any of you guys have pain like that, but it can be pretty intense. So what we determined after the assessment, and this was a purely virtual assessment, 45 minutes, we went through a couple of different things. He had what we called a bicep tenosynovitis. Sounds like a really big word, but bicep is the muscle in the front of the shoulder. Teno is just a tendon. So every muscle has a tendon where it attaches to a bone. And synovitis is just inflammation of the synovial fluid and stuff. And that bicep tendon just runs through a little groove. And how I describe it to people, it has a little jacket around it and it gets fluid in it when it gets really irritated and overused. So he had inflammation of that bicep tendon because it was working so hard. And he said, well, why is it working so hard? And then we did another couple tests, and he had quite a bit of weakness in his subscap muscle, which is the muscle that lifts the arm up and out to the side. So we found another imbalance as well as his external rotators. So I said to him, I'm going to keep things really simple. We're just going to try and calm down your bicep tendon, because he was showing like an inflammatory response because of a mechanical issue. So I sent him home with one exercise, literally one, but I told him to do it about 4 or 5 times a day. I saw him in a week. That achy pain that he had been complaining of that had kept him up all night, he couldn't sleep on that side, he was irritable, was completely gone with one exercise. We got the inflammation down, we allowed the bicep tendon to settle down. Now, I said to him, our goal is to fix those mechanical issues. He was basically overusing his bicep tendon to try and compensate for lack of strength and lack of function in other issues. So we addressed the other issues and we started working on some gentle strengthening, some gentle mechanics, improving the mechanics of how his shoulder moves. basically improving those dynamic stabilizers in a gentle way, because he didn't want to aggravate it, so we started off really simple. And then we talked about trying to improve the mechanics of both the glenohumeral joint and the scapulohumeral rhythm, so that rhythm of those two joints moving. And he was really surprised at the significant change that he had in a week, when he had the issues for months on end. It just had been getting so bad that it was actually affecting his sleep. So what I want you guys to take from this tonight is shoulder issues happen to all of us very commonly. But what you have to remember is when we have painful symptoms, when things are aggravated, pain can usually cause muscles to turn off, so they just don't function the way that they're supposed to. So if we can decipher which muscles have kind of, backed away and they're just not functioning the way that they should be, and we can take a look at your movement patterns. Do you have a dysfunction in how things are moving? Do you have tightness, maybe in your pec region in the front, which is causing that shoulder blade to tip forward? Do you have tightness in, let's say, your rhomboids and a couple of different muscles causing that shoulder blade to tilt down? If the shoulder blade doesn't rotate up, allowing for that movement in your humerus, there's an impingement. So there's muscles that rotate it up, there's muscles that rotate it down. So we have to find that imbalance to be able to get the movement to occur more properly. And that's what our goal is to decipher those poor mechanics, fix those poor mechanics, so that the function and the overall fluidity of the shoulder joint is working properly. Remember, the shoulder is a very unstable joint because it's a ball and socket, but it's easy to stabilize it as long as we find out the issues that are causing the poor mechanics. Does anybody here have shoulder issues? If you do, can you throw up a comment or tap the heart button or something? Because I just want to see how many people have shoulder issues. I know Deb does, I know Joe does. Christine, yeah. So what I want you guys to know is shoulder mechanics can be improved. We just have to figure out what's tight that's causing those mechanics or not allowing something to move properly, what's weak, not allowing that movement to occur or things to be stabilized like they're supposed to be. If you guys have any questions about your shoulder, feel free to reach out to us. Ask any questions that you want. This just gives you a little bit of an insight of how the shoulder moves, especially with it being a ball and socket joint and associated with a specific rhythm, so that the mechanics move properly. Reach out to us anytime. You can message us on Facebook, you can message us on Instagram at fun_physio, or you can even email us. Our email's admin@fundamentalsphysio.ca. We'd love to help you during this time, or if you know anybody else who's having shoulder issues and it kind of seems like a mechanical issue, like we're discussing with that pinching pain or that catching, or even you can't sleep on that side, feel free to share this video with them just to give them a bit of insight and let them know that we can possibly help them. And just because you're at home, don't forget that our care is available in your own home. It's a virtual platform, but we've been doing it for about 4 weeks now. We've had some amazing success, as I just told you with the gentleman that we saw a few weeks ago. So feel free to share and just get the word out that we are able to provide care at home or in your workplace. Have a good night, guys. Happy weekend, because we all deserve it. I know times are tough, but a couple of things to remember: be kind, be safe, be patient, read a little bit more, meditate, do some yoga, get out for a walk 30 minutes every day. Don't forget. Take care.